Parenteral fluid administration. When you're getting ready to administer fluid therapy, it's very important that you assess the patient prior to receiving any therapy, especially their renal status. Water is necessary for adequate renal function and the replacement of insensible losses. The usual recommended formula is 1,500 mLs per day of fluid per square meter of body surface area. There can be a downward or upward adjustment of the formula if it's necessitated by the patient's clinical status. The typical recipient in one that is NPO or is not allowed to have anything by mouth during a limited illness or after surgery, they're the ones that are typically receiving replacement therapy. Replacement rationale is the restoration of pre-existing fluid losses that occur when a previous output has been greater than the intake, or the restoration of present fluid and electrolyte losses, such as the loss of intestinal fluid through continuous diarrhea. The United States Pharmacopoeia has standards and specifications that are used with IV fluid therapy. Particulate matter is basically floaties that might be in the IV fluid. You don't want any particulate matter to be visible when you're infusing any medications or IV fluids. If you have incompatible fluids and you mix those, a lot of time it will create particulate matter. This can cause embolisms and significant problems in your patient if you do infuse them. There's two main types of IV solutions. You have your crystalloid and your colloid. The typical types of fluids are listed here. One thing that we're very concerned about when we're infusing fluids is the osmolarity of the parenteral fluids, and we determine the osmolarity by its relation to the normal blood plasma. So talking about osmolarity, we look at hypotonic fluids. These fluids have a lower osmotic pressure than blood. They act by lowering the serum osmolarity, causing body fluid to shift out of the blood vessels and into the cells in the interstitial spaces. We use them to hydrate the cells and to lower serum sodium levels. Precautions with hypotonic fluids is aggressive administration can cause cardiovascular collapse from intravascular fluid depletion and increased intracranial pressure from a fluid shift into the brain cells, which causes cellular edema. So we don't give hypotonic fluids to patients that are at risk for intracranial pressure or increased intracranial pressure from CVAs, head trauma, or neurosurgery. And we also don't give hypotonic fluids to patients that are at risk for third spacing from burns, trauma, liver disease, or low serum protein levels. With isotonic fluid, these fluids have the same osmotic pressure as blood. It acts by expanding the extracellular fluid compartment. We use it to expand the intravascular compartment. Precautions are there is a danger of excessive administration. It can cause circulatory overload with subsequent diluted concentration of the hemoglobin and lowered hematocrit. Make sure that you, when administering isotonic fluids, assess for signs and symptoms of fluid overload. With hypertonic fluids, These have a higher osmotic pressure than blood. It acts by increasing serum osmolarity, causing the body fluid to shift out of the cells and into interstitial spaces into the plasma. Close monitoring is required with these fluids, and it is recommended that you use an intravenous pump to administer them. We use it to replace electrolytes and to draw fluid from the cells in the interstitial spaces to the plasma for expansion of the intravascular compartment. Precautions: you don't give this to patients that have impaired heart or kidney function, and don't give it to patients that have a condition that causes cellular dehydration, such as diabetic ketoacidosis. These fluids may cause hypertonic circulatory overload and should be infused through veins with large blood volume to prevent irritation and trauma of the tunica intima. It is important to be aware of the calorie benefits of dextrose in water, or DW. If you have 2.5% dextrose in water, this solution is hypotonic when it is in the bottle. 5% dextrose in water is isotonic when it's in the bottle, but it's considered to be hypotonic when it's in the body because dextrose is quickly metabolized by the liver, and when it metabolizes, it leaves water and makes the solution hypotonic. Concentrations that are greater than 10% are considered to be hypertonic. With dextrose solutions, that's indicated for dehydration, hypernatremia, if the patient is not in with circulatory difficulty that has extracellular expansion. It's also indicated for hyperkalemia. It's a vehicle for drug administration, and it's the primary carbohydrate in TPN, or total parenteral nutrition. And it's also used in hypoglycemic emergencies. If you administer dextrose too rapidly, it can result in dehydration secondary to osmotic diuresis that can lead to cellular edema. In other words, it's pulling fluid into the cells. And it can also result in hyperinsulinism. Precautions: extended infusions may result in water intoxications, and it must not be used in conjunction with blood transfusions because it hemolyzes the red blood cells. Indications for isotonic solutions: for normal saline, extracellular fluid replacement when chloride loss has been relatively greater or equal to sodium loss, in the treatment of metabolic alkalosis accompanied by sodium depletion and fluid loss, sodium deficit accompanied by extracellular fluid volume deficit, and initiation and termination of blood transfusions. Indications for D5NS, or dextrose 5% in normal saline, would be temporary treatment of circulatory insufficiency and shock due to hypovolemia in the immediate absence of a plasma expander, and concurrent early treatment with plasma or albumin for replacement of loss related to burns. And it's also used in the early treatment of adrenal cortical insufficiency. The volume and infusion rate will depend upon the patient's clinical status and the therapeutic goal. Precautions: marked electrolyte imbalances can result if you infuse it too rapidly or you have a continuous administration of only this fluid. And continuous infusions of only this fluid can result in extracellular fluid overload. With hypertonic dextrose, when you're administering this fluid, the volume and rate again will depend upon the patient's clinical status and the goal of treatment. and you should use a larger diameter vein to prevent trauma to the vessels, tunica intima. Precautions are going to be the same for normal saline, and you can have the tunica intima trauma if you infuse it in smaller diameter veins. Hypotonic sodium chloride. Indications for use is to provide sodium free plus free water to replace insensible losses, from respiration, skin, etc. It's frequently used as a base fluid for maintenance needs. It's also used in the treatment of hypovolemia when it's accompanied by hypernatremia. The volume and rate of infusion are going to be based on the clinical status of the patient and the therapeutic goals, but excessive use of this fluid can cause dilutional hyponatremia, especially in people that are predisposed to water retention. Indications for hydrating fluids. Again, make sure that you assess the renal status prior to initiating the electrolyte replacement and maintenance fluids. Hydration of medical and surgical patients, and promotion of diuresis in dehydrated patients. This type of fluid, volume, and rate of infusion are based on the patient's clinical status and, again, the therapeutic goals that the physician will determine. Use it cautiously in edematous patients that have cardiac, renal, or hepatic disease. Balanced electrolyte fluids. Indications would be correction of isotonic fluid volume deficits, as in hypovolemia secondary to third space shifting after a major trauma or surgery, where you have an abnormal hydrostatic colloidal pressure. During fluid replacement or resuscitation phases of major thermal injuries or burns, dehydration, and mild alkalosis, where the lactate ion is metabolized in the liver to bicarbonate. Again, volume and rate are going to be based on the clinical status and therapeutic goals of the patient. It's contradicted in patients that have severe metabolic acidosis or alkalosis, liver disease, or anoxic states that influence lactate metabolism. In plasma expanders, the volume and rate again are going to be variable depending upon the usage indicator, the amount of existing blood volume, and the patient's response. Considerations when you are infusing this type of fluid is you need to make sure you're monitoring the vital signs, the pulse, blood pressure, and if you have the ability, the central venous pressure, and urine output every 5 to 15 minutes during the first hour of infusion, and then about every hour afterward as indicated. Make sure that you use caution in patients that have heart or renal disease or others that are predisposed to fluid retention. Understand that severe anaphylaxis reactions can occur with plasma expanders, and it can interfere with type and cross-matching, causing red cell aggregation. The amino acids in your nutritional fluids. The dosage, again, is going to be based on the individual's protein requirements, physical status, the individual's weight, the total daily dose, unless cyclic TPN therapy, and it's evenly distributed over a 24-hour period in a constant drip rate. Precautions. Understand that ketone accumulation can result if it's administered without carbohydrates. TPN has to be administered through central venous access. It cannot be administered peripherally. and TPN is incompatible with many medications. The dosage and infusion rate of lipid emulsions will depend upon the product concentration, the patient's age and nutritional requirements, and the stage of therapy that they're in. The initial infusion rate is usually very slow for a limited period of time while you observe the patient to make sure there's no adverse reactions. You can administer it either peripherally or by a central line. It's often mixed in TPN, but it can be administered as a separate infusion. It is recommended that infusion pumps be used to control lipid emulsion infusion rates. Make sure that you observe the manufacturer's current recommendations for product administration and do not exceed the maximum daily dose. Lipemia must be clear between daily infusions. With pathologic hyperlipidemia, you can see lipoid nephrosis and acute pancreatitis that's accompanied by hyperlipidemia.